So welcome to our webinar. I'm Susan Evans. So this is another in our series of Let's Talk About Fertility. This webinar will be recorded and it will be on the Let's Talk About section on the BXC website. How we're going to manage this morning is Naava is going to give her presentation, and then we will have a question and answer section at the end. If you have questions, you can type them into the chat box, and if you send them to me, to Susan Evans, then I will have the questions to ask at the end. Otherwise, at the end, you can use the raise hand facility and you can ask your own question. If you don't want to be on the recording, then you can turn your camera off or you can change your name, whichever. So yeah, this morning I want to welcome Naava Carman, who has been treating male and female fertility for over 20 years, and gynecology and obstetrics. She has a clinic in London where she focuses on women between the ages of 38 and 45, and she sees people with complex issues. This morning, she's also does a lot of educating and has done training courses all around the UK. This morning, she's going to be talking about the BBT charts and talking about the issues around how we can look at the BBT charts and how we can use those with women's particular issues. So without any further ado, I will hand it over to Naava. Welcome, Naava. On behalf of the British Acupuncture Council, we're all looking forward to this morning.
G'day everyone. It's nice to see some faces because then I'm talking to somebody, but I fully understand those who have not turned their video on. That's absolutely fine. So a lot of you have seen me around over the years, and probably more in lockdown than you've ever seen me being visible on the Mini Monday Masterminds, which are now happening once a month at the end of every month. A lot of that has been talking about some of the complex work I do. And so when we're looking at BBTs today, I'm going to start sort of in a fairly general way, but then I'm going to just launch a little bit into the conditions that are associated with the BBTs. And I want to look at them in a bit of a new and interesting way. It just might make you think about things, spur you on to do more research, and maybe even come and train with me if you like my approach. So let's start by talking about a normal menstrual cycle, and I'm going to share screen and I'm going to show you my slides. If anyone has a problem, then just let Susan know and she'll convey that to me. Here we go. Alan, can you give me a nod if you can see that? Thank you. All right. Sorry, I'm going to have to stop share. It's not allowing me to move it forward. And there we go. Okay, so here we are looking at a normal menstrual cycle, and I'm going to talk you through this. So the body starts by doing something called recruiting a cohort. It goes into the follicle, into the ovary, and finds loads of primordial follicles, and it grabs a load of them and it brings them up. And out of those follicles, over a 3-month period, one will end up being ovulated. And it really is important to understand, for me in my practice, and what I teach and what I encourage all people who are working with fertility to know, is that you need to be working with a client for at least 3 cycles to get a good result. And I think we do ourselves a disservice in our profession when we take people on willy-nilly, because although yes, we meet them where they are on their journey, I feel in so many ways we set ourselves up for failure because we don't have enough time to do our job from a TCM point of view, because when we're dealing with fertility, really our work should be done before someone gets pregnant. But also just understanding the Western medicine behind this means that the environment in which these follicles are recruited, these eggs are matured, needs to change completely to get a different outcome. And that takes a little bit of time. So the follicles are recruited from that cohort, those kind of inert follicles. And then gonadotrophins, which are LH and FSH, luteinizing hormone and follicular stimulating hormone, are produced and secreted by the pituitary. And pituitary is an important organ in the body. I'm going to talk about that a little bit more when it comes to polycystic ovary syndrome and looking at things like sex hormone binding globulin. Pituitary is a bit of the body that is like the thyroid in a way. They function as master switches in the body, and if they're not working, there's lots of clues that are scattered around people's case histories, and allows us to zero in really firmly on what we need to do from a TCM point of view too. So after that has happened, the steroid hormones, which are E2, which is estrogen. There are 3 different types of estrogen, and we focus in fertility on E2, and P4, which is progesterone. They're made and secreted by the ovary. The FSH stimulates the follicles and it converts testosterone to estrogen. I'm just going to move my little screen around. The FSH, and the estrogen then rises and it facilitates the luteinizing hormone to release. So when your clients are peeing on sticks and they're having an LH surge or a rise or a positive showing, which they not all that many people do, they're really difficult to use those sticks sometimes, especially if there's any kind of polycystic ovaries or autoimmune thing. So they can be quite stressful to use. But when everything is technically working in a normal menstrual cycle, the estrogen will rise, it will trigger the LH to go off. That'll be detected in your stick. And then you'll go into ovulation up to 72 hours later, but 99% of the time it's about 24 hours later. Sometimes with polycystic ovaries, you see a big gap, but mostly it's quite quick. So the LH surge comes again from the pituitary. You go into ovulation, and then progesterone is produced instead of estrogen by the granulosa cells, which are a set of cells that line the inside of the ovary and protect the egg. If you're not pregnant, the follicle collapses to form the corpus luteum. And this is an interesting one when it comes to working with fertility and getting scanned, because your sonographer has to be skilled enough to understand that sometimes a corpus luteum can actually be left over from a cycle before. And a number of times in a less skilled sonographer, I've had issues with clients being told they've already ovulated when actually it was a leftover follicle from the month before, and that has messed around with their cycle, their psyche too. So you really need to have a really good understanding about what a corpus luteum looks like when it's current. And if there's no pregnancy, gradually the progesterone will go down and the FSH will rise, and then you'll end up with a period. And this is a traditional textbook basal body temperature chart. And the best place for me to start, I think, is to talk you through what this looks like. Broadly speaking, the yin phase is the follicular phase and the yang phase is the luteal phase. Follicular phase is the pre-ovulation phase and luteal phase is the post-ovulation phase. Now, why am I talking about traditional textbook basal temperature charts? Well, because the fact of the matter is I'm going to be a little bit radical and disagree with what I see in these charts. I have been, I talk about this a lot, I've been auditing my practice for 20 years. And what I've discovered is what I see on the ground with clients is very different to what I see in textbooks. But let me start with the textbook. So you beetle along. Ideally with a BBT, your temperature will be between 36 and 36.3. It's fine if it goes up to 36.4 occasionally, but it should be nice and low. Then some women have a dip, some women don't. If they don't have it, it's not a problem. If they do have it, it's not a problem. But you should have a nice jump up by at least 0.3 of a degree, and your temperature in your luteal phase should be at least 36.5 or higher. And then from there, you should continue along until just before your period, and then either on the day of or the day before your period, your temperature should drop right back down again to where it was at the beginning of the follicular phase. And this is a sort of picture. Now, in traditional textbooks, what they say is your LH surge should be around day 13, and day 14 should be the start of your luteal phase. And then from there, you should have a 14-day luteal phase, and then that brings you to a 28-day cycle. Now, in my practice, this is what I look for. A little bit different, because the fact of the matter is that out of the 40-odd women I would see of a week over a course of a 20-year period, in fact, let's just say in a year, over the course of a year, probably 99% of them, all but 2 of them, will have a 12-day luteal phase, and that is absolutely fine. Of those, 2 will have a natural 14-day luteal phase, and after treatment, probably 1 of them would go down to 12. So really what we want to see is ovulation that happens from day 16. 16 plus 12 equals 28. And in fact, what I see further auditing my practice is that the women who have easy conception, better pregnancies, better postpartum experience, they ovulate between day 16 and 20. And that gives you a 28 to 32 day cycle. And that is absolutely fine. So I say this because I see so many people really setting themselves up for failure. If you're trying to get a patient ovulate on day 14 and they're consistently having a 26-day cycle and you're thinking, okay, there's a problem. What am I doing? What's happening with the progesterone? No, it's absolutely normal. That means you're doing it right. You have a 12-day luteal phase from a day 14 ovulation. But ideally, I would push my clients to ovulate between day 16 and 20, which gives them, in my experience, the optimum environment hormonally. It also means that we're optimizing the quality of the egg within the cycle. It's not being released prematurely and therefore is immature. It's not being released too late and therefore is too mature for fertilization. It's just that optimum window that you're looking for. But nothing else is different. The temperature is the same that I'm looking for. So ovulation between day 16 and 20, a 12-day luteal phase is fine. The one exception to that, and I discovered this the hard way through about 3 months of free treatment. I had a client who was just not doing what I thought she should be doing, and I couldn't understand it, so I kept going. And in the end, I sent her for a tracking cycle. So she was monitored throughout a cycle. And what we discovered is something that I have only seen once, but I mention it here so no one else gets tripped up, which is that we know that a luteal phase is able to be 17 days long without any conception happening, and that is still in the normal realm. It's extremely unusual, but it is possible. Most of the time, if you're over 12 days in the luteal phase, you're going to be, some sort of conception will have happened. And this particular client had a natural 16-day luteal phase, and that's just what was happening with her. But I learned it the hard way and the expensive way, so I share it with you here so you don't trip on that yourselves. Let's move to the next bit. Let's look at endometriosis and the temperature chart. So these are all taken from my clinic. This is all taken from actual patients. And depending on the time that we take today, I do have some case histories we can go through, but I'm not sure that we'll have time for that. So what you need to know when you're looking at these charts, a chart with someone with endometriosis, is that endometriotic tissue is both estrogenic and androgenic. And what that means is there's too many male hormones circulating, and there are too many female hormones circulating. It's a really out of balance environment for a follicle to be, an egg to be recruited and matured. And the egg quality is impeded because of that imbalanced hormonal environment. And when you have endometriosis, you also effectively have an autoimmune disease. So the immune system is involved. And all of those things affect egg quality, affect implantation. And that is why when you're looking at an endo patient, you've got to approach them a little bit differently. And you've got to understand why fertility might be a bit more difficult for them beyond the stuff we know about in terms of pain and so on. Now, what we also know is that progesterone receptors have been shown to be dysregulated in the endometriosis endometrium. So that means that you might measure progesterone in blood, but there's still something wrong with how progesterone is able to be uptaken inside the body. So that tells us automatically that whenever you see someone present with endometriosis, you've got to be looking at supporting spleen and kidney yang there. There's always going to be an element of deficiency in those areas, even if they're not overtly presenting with it. And what happens when the endometrium is resistant to progesterone? It doesn't counterbalance estrogen. And when there's an unopposed estrogenic state inside the body, that in itself causes issues. You don't get rid of the estrogen you don't need very easily. And often you find that constipation or sluggish bowels is associated with endometriosis. And when you're not having regular, effective, emotionally satisfying bowel movements, and that latter is really important because that means that you're triggering the appropriate hormonal response. If you're not having an emotionally satisfying bowel movement, you're not actually getting rid of the excess estrogen that's circulating around your body. So talking about poo and endometriosis is really important. And when I'm looking at a temperature chart, I'm actually getting them to mark down on the days they're having proper bowel movements. Now, what does a proper bowel movement mean? And sorry, this does have a place in the conversation about basal body temperature charting. Apologize. That means that you don't immediately have to move your bowels the second you eat. That's an allergic reaction. But I would like to see a bowel movement happen that is, as I described, 2 or 3 times a day. So if that's not happening, then they're already erring on the side of constipation. And I have a colleague who has a poo chart. I used to have one too, but you just got to get used to talking to clients about what poo is actually like. It should be nicely formed logs. Shouldn't be like Mr. Whippy. It shouldn't be like rabbit poo. It just should be kind of a normal bowel movement. And what is normal for one person is not normal for someone else. And this was rammed home to me many years ago. And I talk about this in the diploma when I had a client with a black tongue, and I asked her, "Are your bowel movements normal?" And she was like, "Yeah." And then I realized I was asking the wrong question. You can't ask if bowel movements are normal. You have to ask what their bowel movements are, because normal for her was moving her bowels once every 3 weeks. So get to know your client's bowel movements. Yes, there's some better faces there. Yes, I have a fabulous picture of a black tongue. It's amazing. It's one of my favorite ones. Also, as you can tell by how excited I am about tongue pictures, I do not get out enough. And this was before the lockdown and the pandemic. Right. The other thing you need to know is when you're dealing with endometriosis, most of you probably know if you've come to see me, I specialize in reproductive immunology. So my focus is looking at gynae and fertility and hormones through the eyes of the immune system. But what you need to know is that when you're dealing with endometriosis, like you do with any autoimmune stuff, there's always a pull to the status quo. And what I mean by that is the body gets used to behaving in a way that it's used to behaving. And so what you'll find is that you go in and you intervene, and in the first month or so, you'll have the most beautiful, perfect chart, and then you'll never get it back again. You'll do the same thing again, and it won't happen again, and you'll wonder why. And that's because when you have someone with an autoimmune condition, you'll see that the chart just pulls back to where you started. So you've got to keep changing up with treatment. You've got to keep the body a little bit uncertain and trying new things. So when you're seeing an endometriosis chart, you've got to keep it moving. When you're diagnosing endometriosis these days, an MRI is the gold standard of care. And that's because an endometriosis can be identified by laparoscopy. That's very invasive. Sometimes if you've got a good sonographer and a good machine, it can be identified by ultrasound, but not always. And endometriosis also is often complex. It's in different bits of the body. So an MRI will identify the bits of the body it's on. So for my clients, for example, when they go and they have an MRI, because I deal with the more complex end of things, a number of times in the last year that has enabled surgery to be performed. And I'm actually in favor of some surgery initially, not in the awareness that surgery has complications in terms of possibly creating more scarring. But it does allow us as Chinese medicine practitioners to start with a clean slate. And that MRI allowed a number of my clients to have up to 3 surgeons in the room, one who dealt with bowels, one who dealt with ovaries, and the other one who specifically dealt with the ureterosacral ligament. So it just, if you have the ability to have access to an MRI, it does change how it is treated. Now, the other thing I want to talk about before we move on is diagnosis from a TCM point of view. What I see often in the textbooks is no mention of cold in the uterus. And I rarely, if ever, see endometriosis without cold in the uterus of some kind. So really understanding what cold in the uterus looks like and asking questions that ensure that you understand where it's coming from is really important. And don't forget that cold can come from heat or it can come from cold. So understanding the pathological flow of your client, how they got from their teenage years with a problem or without a problem to where they are now, will often tell you about that heat and cold transference. So you can touch someone's tummy and have it be burning hot, but still have cold in the uterus. You can have them have hot flushes and night sweats, but still have cold in the uterus. So to understand that flow when you're diagnosing is really important. Now, what do we look for in a temperature chart? So you can see here. And now, if you would like to contribute to this, I'd love to. I'd love a little bit of interaction. On your chat button, you can have the option of sending a message to Susan Evans if you have any questions. But if you want to participate for me to see, what do you notice in this chart? Send the message to everybody. What do you notice about this chart in the follicular phase that's significant? Have a little look at my chat. So what do you notice at the beginning of the chart that is significant? Can anyone have a guess? So what you're seeing is a temperature. Yeah, that's right. Too high from the get-go. Okay, good. So I know what the pause is before I launch in. Thank you. All right, so yes, you're all right. The temperatures are too high. And what does it mean when the temperatures are too high? It means that there's an element of blood stasis there. It's not, with endometriosis, going to be just a matter of heat or yin deficiency. There is always going to be a blood stasis component. It's like what happens, the body doesn't clear properly. It doesn't clear and then start again as it should. I use an analogy of being on a beach. You probably heard me talk about this before, that the waves should come slowly, 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 build up the sand, and then a big wave will eventually come and knock that sand away, and then boom, it starts again. It's a little bit like what happens with the endometrium, with endometriosis. Quite often, the periods will come, but they don't clear properly. So the lining of the endometrium builds up, the endometriosis builds up around the body, and it never really clears properly. So that is why dealing with blood stasis is so important, and it's really important not with the period, but before the period comes. The time to deal with blood stasis and endometriosis is actually in the luteal phase. You have to ensure that the body is going to properly clear and start the new cycle anew, both from a TCM and from a Western medical point of view. We know that breaking blood lowers FSH. It makes a really big difference. It lowers estrogen. Moving chi lowers androgenic hormones. So working on breaking blood in the luteal phase is going to affect the follicular phase of the next cycle. Don't wait until they're having their periods. Now, I go into this in a lot of detail when I talk about reproductive immunology. I'm not going to spend too much time here, but prime tip to think about it like that. So let's move now to the next chart and just have a little look. I wanted to show you a couple of options. I'm just going to move my screen around because I've got everybody up. I just wanted to show you a couple of options. Where does everybody think ovulation occurred here? Can anybody tell me? Use the chat function and let me know what you think. Where did ovulation occur? Yep, I can see why you would think day 33 for sure. Nope, not day 8. Not day 18. Now I'm going to put you all out of your misery. Can you see my cursor? It occurred here, day 40. So when it comes to endometriosis, it actually sometimes looks like a PCOS chart, a really super long follicular phase and a really short luteal phase. Because endometriosis affects all sorts of organ systems and body systems, it can affect the pituitary function can be involved in that. It can, all the male hormones can interfere in how everything works. You can sometimes see an endometriosis chart be really confusing. And so what you're looking for is the 3/6 rule. Does everybody know that? Alan, I always look at you for a little indication because you're up on my screen. Okay, so what you're looking for is the 3/6 rule, which means you're looking for 3 temperatures higher than the 6 that have gone before. And we were doing, by the way, cycle monitoring here. So I had an external validation for this being ovulation. And it was, as you can see, an incredibly ineffective ovulation with a super short phase. So I treated only in the follicular phase, and gradually the follicular phase shortened until we had a normal luteal phase. You don't need to bother treating the luteal phase at this point. So you have 1, 2, 3 temperatures higher than the 1, 2, 3, 4, 5, 6 that have gone before. And yes, I know these are quite similar, but it's still that shape you're looking for. And I'm going to show you this again in the next slide for PCOS. So it's a way to look at ovulation. And it can get confusing when you're dealing with complex cases, but just seeing that rough biphasic guide and seeing 3 temperatures higher than the 6 before can be really useful. Now let's look at polycystic ovaries now and look at the next slide. Why can I not change my slides? Sorry, people. I'm going to have to stop share and share again. Okay. So let's look at PCOS. What you need to know about PCOS is there's always going to be some sort of kidney and spleen deficiency, always going to be some kind of phlegm damp, and always going to be some kind of blood stasis. It will massively vary in terms of the proportions client to client, but there'll always be a bit of what I call the diagnostic triumvirate. There'll always be those 3 things in the mix. Now, I look at a whole series of blood tests to help me diagnose this. I look at scans. I look at those in quite a big depth because it helps me interpret the chart, helps me refine my TCM diagnosis. Again, I talk about this a lot in the PCOS module on the diploma. But for today, I want to highlight, where does PCOS come from? And it's a really interesting conversation to have, epigenetically speaking. It's a combination of our genetic inheritance and our environment, and it's multifactorial because of that. And years ago, I came across a fabulous quote, and I'm going to read it to you now. Genetics doesn't make the car turn into a KFC drive-through, but it could influence our desire to do so. And I think PCOS is a little bit like that, in the sense, what we do in our lives, while patient A could have a really bad lifestyle and be absolutely fine, patient B with a genetic inheritance of PCOS or factors that predispose to PCOS would live the same terrible lifestyle and end up in a lot of trouble hormonally. So it's a combination of what you've inherited and then what you do in your own life. And understanding the fact that there's both of those components there helps you understand that pathological flow when you're looking at where it came from a TCM perspective. So you're looking at, is there a genetic history of diabetes, for example? Is there a history of autoimmune things in the family? Like, you're looking at the family, but then you're also looking at how that patient's lived their life and figuring out what have they done that tipped them over into this dysfunction. The other thing you need to know is the pill and PCOS. Probably if you've treated it, you know it can be a big disaster for PCOS. It can tip off PCOS. It can tip you off into post-pill amenorrhea really easily. And of course, it's a catch-22 because Western medicine's biggest tool for treating PCOS and the acne and the irregular cycles and all the things that go along with PCOS, its biggest tool is the contraceptive pill. But in taking it, it is the sort of its worst enemy. And that's what we're dealing with by the time a lot of clients get to us. So there's research into animal PCOS, for example, that shows that if the brain is exposed to androgens during a critical period of development, that future menstrual cyclicity will be lost. What that really means is that when you're given the pill at 14 years old, you are predisposing yourself to have irregular cycles later on in life and have all the issues that PCOS brings later on in life. So when you're having a PCOS patient and they haven't yet been treated by you, what you need to understand is those eggs, and thinking about that normal menstrual cycle and what I was saying at the beginning about eggs being recruited and matured over a 3-month period, that at least 2 of those 3 months when you start treating, that egg is going to have been recruited and matured in an environment which is suboptimal hormonally speaking. So you need at least 3 cycles to treat to change the hormonal function, which in turn will change the egg quality and the environment in which those eggs are coming. And if those eggs are indeed in an abnormal environment through all that time, and part of that abnormality is that progesterone doesn't work very well, then perhaps we can go some way to understanding why miscarriage is a feature of PCOS. The other thing you need to know is the ovary is very sensitive to an increase in insulin, and it responds by making more testosterone and therefore driving more symptoms to occur. So understanding that treating insulin and blood sugar regulation and male hormones, treating that as the center of PCOS, is the core of what you need to know to be successful in treating them. So let's have a little look. I'm not going to go in great detail to all the male hormones and the studies of them, but even if you have a basic understanding of the environment that needs to change and talk to your patients about that and give yourself enough time to work, then that will really increase your chances of being successful. I talk to my clients about the fact that after I've treated them for 3 to 4 cycles, and it's quite an intense sort of time I treat them, they're often doing some sort of therapy, they're often working on lifestyle, they're seeing a functional medicine nutritionist I work with. It's a kind of an intense period of time. They're having herbs, they're seeing me a couple of times a week. After that point, it's kind of like turning back the clock. And from there, I see a bell curve where about 4 months later, most of the conceptions happen. So from the time they walk in my door to conception, it's usually about roughly 7 months. And after that, I see the efficacy of what I do go down. So just to be able to talk to your clients about their expectations and not to put too much pressure on yourself right off the bat is really important, to stage what you can expect for them to see. If I see a lowering of the follicular phase between 1 and 4 days every month, I know I'm in the right place. So let's just look at this temperature chart now. And then I'll talk to you a little bit about some other research that I thought was really interesting, and also the use of, I thought, talking about Agnus castus was quite a useful one, because even those who aren't herbalists can use that as a food supplement. It can be really interesting. So let's look at the chart. So first thing to say is what's happening with the temperature. Anyone notice something particular with that temperature? What do you see there? Use the chat function and tell me what you're seeing. Don't forget to ask your questions directly to Susan Evans so I can answer them at the end. What do you see in this temperature chart at the beginning? That's right. Yeah. What else do you see here? Can you see my cursor? What else do you see here? Have a look at the temperatures. Remember what I said about what we'd like to see? Look at the temperatures. A lot of them, at least initially, are below 36. That's right. And so what does that mean when the temperatures are low from the get-go? What can that tell us? That can tell us that there is quite possibly some thyroid involvement there, and there's pituitary function imbalance there. So that would be another way. The reason I mentioned I always start with getting a good panel of bloods, including thyroid and all the hormones, is because that tells us a lot about what we can expect from our clients without help from the Western medical community. And it also gives us an idea about, again, refining your diagnosis. What diagnosis would you make for BBT temperatures that are this low? Where would you be with a PCOS patient? Where would you know you'd need to start? What TCM diagnosis might you make? That's right. Yang and warming kidney yang. Yeah, there's always going to be a spleen, a kidney, and maybe even cold involvement. Yes, all of those things. So it gives you a little place to start to understand that, both from a Western point of view and a Chinese medicine point of view. Where do we think ovulation happened? I'm going to remind you what I said about most luteal phases being 12 days. Where do we think ovulation happened? And again, this is done in a tracking cycle, so I can be very clear when that is. And this is why PCOS charts are really confusing and why I wanted to show this to you, because at least initially when you're starting, at least initially when you're starting to treat, nope, not day 15, and know why it looks that way. It actually looks like that way about here, right? It looks like really early. But actually, funnily enough, it's here on day 21. So we have a 33-day cycle, right? 33 minus 12, you're going to be ovulating around day 21. And that's borne out in a cycle. So remember what I said about the 3/6 rule? Don't expect to see that, at least initially, with a PCOS patient. It's really hard to tell when they're going to ovulate. And you can see all of this spikiness, all the stress that's showing in the body. You can see that there's a lot of involvement of liver qi stagnation, a lot of heart stuff involved. And that is going to cloud your ability to tell when someone's going to be ovulating. And not only that, but the LH surge doesn't work because the hormones are so messed up, they can be weeing on sticks forever and not show positive. Or with PCOS, they may show positive all the time. Because sometimes that's what happens, because the LH is on or it's too high all the time. So all they're going to do is show positive. So when you're treating PCOS and you're looking at a chart, don't get too caught up initially on that chart. As you treat, it'll start to become biphasic. It'll start to become more normal. And sometimes the only way you can tell when someone's ovulated is counting back 12 days or doing a tracking cycle. So again, just wanting to provide some reassurance for you all that it doesn't mean that you're not doing a really good job. It just means that everything is messed up inside, at least initially. So you're going to have to do a bit of work before you can fix that up. Let's talk for a minute about Agnus castus. So Agnus castus has a lot of good qualities. And if you're not a herbalist and you want to do a little bit of something that can help, then this might be a useful one for you. It regulates mood, which is really nice, because a lot of the time when you're treating fertility, patients are feeling low, and PCOS too. It supports adrenal function. It lowers prolactin levels, but that's dosage dependent. So I'm going to give you a little dosage guide for it. Most importantly, it does something called slowing the pulsing of GnRH. It's something I go into in quite a lot of detail. You can actually tell that there is a from a Western point of view, there's a pulsation that should be happening at a particular pace that occurs between the different organs of the body, the pituitary, the hypothalamus, the ovaries. It should all communicate in a pulsation. And if that pulsation is too fast or too slow, that's when you get hormonal imbalance. And you can translate that really accurately into TCM terms from looking at blood tests. And it can give you a really good idea about which bit of the body you need to treat. But what you really need to understand is when that pulsation is working, then the hypothalamus and the pituitary and the ovaries and the adrenals all talk to each other really well, and everything functions. And it helps the body to be responsive to estrogen, be responsive to progesterone, and then that everything calms down. So using Vitex agnus castus can help slow that pulsation down. And that in turn helps progesterone levels rise. It helps estrogen levels drop. It has a lot of widespread benefits. Sometimes Vitex can be hit and miss for some people, and that's because it acts on the opioid receptors in the brain and not directly on the hormones that are expressed from the ovaries. And that bit of the brain is responsible also for producing stress hormones. So unless the person is also doing all the lifestyle stuff you've asked them to do, then agnus castus is going to be of limited use. It's not a magic bullet. That bit of the brain doesn't function well in PCOS women. And when you are having lots of insulin, it exacerbates, it makes that area of the brain even poorer in terms of its response. So having a little bit of agnus castus plus lifestyle plus acupuncture, that can be a really fantastically powerful combination for charts that look like this, where you just can't see that biphasic pattern and you just can't identify when ovulation is happening, but they do have these irregular cycles. So Vitex I would not use for amenorrhea in PCOS, but for these irregular cycles, that is a beautiful option for you. I'm going to give you a little bit of guidelines for it. This is a good time to write down. So if a woman has a delayed ovulation with a slightly high LH in her blood tests, we want to use Vitex only in the luteal phase. And this is roughly for women who have a 32 to 45 day cycle, just in the luteal phase. For women who have a longer time between cycles, or if they do have amenorrhea, then you can use it daily, minimum of 4 months though. And then once the cycle has become even somewhat established, just switch to the luteal phase. All dosages always in the morning and around 1500 micrograms. Should I repeat that for you all? Okay. If a woman has a delayed ovulation, and if you're seeing a slightly high LH in her hormones, if you know how to read blood tests, you use this only in the luteal phase. And this indication is for women who have roughly a 32 to 45 day cycle. For women who have longer periods of time between cycles or who have amenorrhea, then you can use it daily for a minimum of 4 months. 4 to 6 is about right. And once there is some kind of cycle established, so it's come down to somewhere between 32 and 45 days, then you switch to using it only in the luteal phase. Now I want to tell you about a bit of research. This is Mark's area. We've got Mark Bovey today, so I'm going to speak a bit to you on this. There's a piece of research that came out from the French National Institute of Health. And a guy called Paolo Giacobini and his colleagues found that you can actually trigger PCOS, and you can trigger it before birth by exposing people in the womb to a hormone called anti-Müllerian hormone, or AMH. You've probably heard about this when it comes to fertility, but an AMH is high when it comes to polycystic ovaries. And what researchers discovered is when you have PCOS, you have about a 30% higher level of AMH than normal. And this is known to run in families. So they looked at pregnant mice and they injected AMH into pregnant mice. And as the female offspring of those mice grew up, they displayed lots of those hallmarks of PCOS, later puberty, infrequent ovulation, delays in falling pregnant, fewer babies. And the excess hormone, the excess AMH, also triggered a set of brain cells that raised the level of testosterone. So it's really interesting. They find the cure was a drug that we see used in IVF cycles called cetrorelix, which basically blocks the action of GnRH on the pituitary and suppresses LH and FSH. So I think that's really interesting. So these are your clients, for example, who have had an unsuccessful IVF cycle and then fall pregnant the month after, there's something about the suppression of those sex hormones, even briefly, that allow the body to reset itself and function well. And I've taken to testing my clients AMH on the month after they've had an unsuccessful IVF cycle. Unfortunately, now it doesn't happen very often in my practice, but when I was doing it earlier in my practice while I was still learning, what I did see is a drop in AMH. And I found that quite positive because, of course, as AMH drops, also can it raise. So it's not a fixed thing. So I thought that was just an interesting way to help everybody understand that you are dealing with people who have a real propensity to a problem before they have even come to you. So again, just reinforcing the idea that you really need time to treat this condition. So I want to give you another temperature chart now to PCOS one, and then we're going to move on to the next bit. Okay, looks like if I talk too long and don't keep my slides moving, I've got to reshare every time. Sorry, people. Here we go. Where's ovulation happening here? Can anyone tell? So this is the same woman, and now this is 2 more cycles along. Where do you think this is a much more obvious one? Where do you think that's happened? I can see why you'd think that because you counted 12 days, but actually it's here. It's on day 29. See, this is 3 days higher than the 6 that have gone before. So you're always doing a little teeter between counting your 12 days, looking at the shape, looking at the 3/6 rule, and seeing where you get to. And this is a typical pattern. The reason I'm showing you this from the same client is because this is typically what you see, that completely messed up cycle where you couldn't see anything at all. And then slowly, the follicular phase reduces. You see, it's also come up. It's not as low in terms of temperature. So we've supported the spleen and supported the kidney. And slowly it comes down. And slowly that luteal phase will elongate. So right now, you're still not paying any attention to the luteal phase. It's just doing its own thing. That will naturally elongate as the follicular phase comes down. So this is the key thing to understand with treating PCOS. You're going to focus always on the follicular phase and only get to the luteal phase right at the end if it's still not long enough when all the other stuff is done. Make sense? Okay. Right, let's look at thyroid. What do you see about this? Look at the temperatures. What can you tell me about this? You see they're very low? And I decided to use this to make a point to everyone, which is as much as we focus on charts, as much as we think they're important, as much as they are hugely useful and important, what you also need to understand is there's no such thing as perfection. And in fact, it doesn't need to be perfect. This is a pregnancy chart. So it doesn't look like it should, right? It's too high at the beginning. It's too low overall. The luteal phase is low instead of high, but yet this is a pregnancy chart. And I show you this because this is what undiagnosed hypothyroidism can look like. And it doesn't have to be perfect. So it's about understanding the charts. It's about understanding what you're seeing. So what do I see here? I see somebody who needed to have a blood test and to check her thyroid. I see somebody who, by the time we'd had this blood test, got it all diagnosed, by the time she got to about day 27, she was on thyroxine. This was absolutely a case that needed help. And that thyroxine supported that pregnancy. I think without it, that patient would have miscarried. But you can see she actually, believe it or not, she ovulated here, day 15, round about the right time. And she had a positive LH surge. This is not a client who has polycystic ovaries, right? This is just a standard cycle for a client with hypothyroidism. And she ovulated here, spiked down and up. But her body struggled to maintain that luteal phase because that yang wasn't working. The spleen needed support. So that 3/6 rule, you couldn't make work here, You could only figure it out by the fact that she got an LH surge, and we counted back from when she should have had a period, potentially. But the most important thing for me in this chart was not trying to get it perfect. It was understanding what it told me about her thyroid from a Western point of view, and her spleen and her kidney yang, and the stress around ovulation that I needed to deal with. And that liver qi stagnation that was showing. So that chart doesn't have to be read always in a microcosm. It can be read as a macro, as a big picture clue to where you need to be going on with. So let's talk just a tiny little bit about hormone levels. I'm just going to give you like the briefest smidgen of information about it, because I'd like, sorry, this share thing's driving me nuts. Let me try this again. Right. I'm going to talk to you about it with this in mind. So let's just take a smidgen of time to tell you about TSH. Can I have a little hand raise of people who know what TSH is? Let me just have a look at my my screen to see what everybody's doing. Okay. So of those of you that I can see, and don't forget you can raise your hand with a little thumb if you're not on video. Okay. So some of you know, but not that many. So I'm just going to spend one moment. When you're checking thyroid, there's different kinds of thyroid problems, and I talk about this a lot because unless you understand how they work and how T3 transforms into T4, they're complex. But the one thing I can tell you is that if you see a GP do a basic thyroid test, they're going to measure something called TSH, which is thyroid stimulating hormone. And the reference range for TSH is really big, and there's a lot of debate over it. And in this country, it goes up to around 5, and anything below 5 is absolutely fine with the GP. But what you need to know from a fertility point of view, that your TSH really needs to be between 1 or 2, certainly no more than 2.5. And if it's not toward 1, ideally, then the thyroid is in trouble. I teach you in my diploma how to figure out what sort of trouble it's in and help the client get treatment. But at least for now, if I can tell you about the TSH and you see it in their bloods from the GP, you have a clue to find out more information, to refer to someone like me, to work with a functional medicine nutritionist, to actually do a little bit of detective work around why is that thyroid not working properly. If the TSH is fluctuating above 2.5, or ideally not nice and low between 1 and 2, you know the thyroid is in some way impaired. And that's when you see these cycles that are just all over the place. And if you have a look at this is a really good example of what all over the place looks like. It's low, then it's high. There's an ovulation here at just about the right time. Ovulation in this case is day 15. And it's a pretty normal cycle. They slightly short luteal phase. It's a 27-day cycle. You see this big space, this big gap as the body jumps into ovulation around day 15. Instead of a spike down and then a jump up, it's had a couple of days of stepping down and then a couple of days of stepping up. That's a characteristic I look for when there's some kind of impaired thyroid problem. Can you see my cursor? You can see where I'm kind of circling. So that's what I'm looking for when I'm looking for hyperthyroid, not just the temperature, but also is there a pause between the LH surge and the actual getting into the luteal phase? And that gives us a little clue about what's going on. There's also a really interesting study I found that showed that patients who had spleen qi shu and spleen and kidney yang shu had a basic metabolic and a thyroid gland function which was markedly lower than the normal population. And it was a very interesting study that I found in an autoimmune book actually, where they took a population and analyzed them not according to Western medical parameters, but according to TCM, and then extrapolated back out. And so that tells me that when you're seeing a chart like this, you're never going to go wrong if you're working with the spleen and the kidney. You're always going to be heading in the right direction. All right. Let's look at the next piece. Let's look at hydrosalpinx. Can I have a show of hands? Who knows what hydrosalpinx is? Okay. I'm going to talk about hydrosalpinx because if you're dealing with fertility, you are going to be dealing with it with or without knowing about it. And you need to know about it enough to know that a lot of clinics don't deal with it well. And they need your involvement and they need your help to understand what it is, their options of how to deal with it, and then how it can massively impact their ability to get pregnant either naturally or with an IVF cycle. So what is hydrosalpinx? It refers to a fallopian tube that's blocked with a watery fluid. Excuse me. Here you swallow. To break it down, hydro means water and salpinx means fallopian tube. What causes hydrosalpinx? A number of things. Usually some kind of previous pelvic disease, sexually transmitted infection, but a previous surgery could do it. So could endometriosis, that predisposes you to hydrosalpinx. And a lot of women don't experience any kind of symptom at all. But sometimes what they experience is constant or frequent pain in the lower abdomen, and they can also experience unusual vaginal discharge. So when they experience, and interestingly, those two symptoms are also a red flag for ovarian cancer, and they are certainly a red flag that we want to send our patients back to the GP to check before we trot down the hydrosalpinx road. So does everyone know about this, like bloating, unusual discharge, infrequent sharp pains in the lower abdomen? Those are red flags you need to send back to a GP for. Now, when people are having these odd symptoms, it looks like a miscellaneous collection, but if you can put them together in the context of hydrosalpinx, they all kind of fall into place and make sense. And I think a lot more women have this than we realize. And you could have a partial as well as a full hydrosalpinx. You can have a partial as well as a full blockage. You also need to know that when you're dealing with hydrosalpinx, one of the ways that the only way you can really tell if it's there is if you've had your tubes flushed and flushing hasn't worked. Sometimes the flush can actually free up the tube that was previously blocked. And so after they've had their tubes flush, A, they don't have these miscellaneous symptoms anymore. And B, actually, there's a huge study that shows the simple act of flushing out the tubes improves fertility, improves conception rates exponentially. So all women who have fertility troubles should have some kind of, we call it hysterosalpingogram, some kind of tube flush as a first line of investigative and sometimes curative treatment. So you need to make sure your clients have had that. Now, I need to explain to you why this is significant if you have a hydrosalpinx and you're going into IVF. Clinics are not altruistic places. They want to take your money and give you IVF. And often, especially outside of London, and the more I work with my network of practitioners, the more I realize that outside of London, people often just say, yeah, come in. Yes, we know you've got a hydrosalpinx, or we'll just go to hydrosalpinx, but we're not going to do anything about it unless the first cycle doesn't work. And that is a total load of bullshit. And you need to be able to call them on them and empower your clients to call them on them. And I'm going to explain why. So an academic review, this is one I use, but there are millions of them out there, maybe not millions, but lots of them, examined 5,592 women undergoing IVF. Of these women, 1,004 had untreated hydrosalpinx, and 4,588 had another type of untreated tubal blockage. Between these groups, doctors performed over 8,000 total embryo transfers, and the following success rates were observed between the two groups. Women with untreated hydrosalpinx had a pregnancy rate of 19.67% versus 31.2% for women with other types of blockages. Implantation rates were, now here's the interesting bit, 8.53% for women with untreated hydrosalpinx compared to 13.68% in control. Delivery rates for women with untreated hydrosalpinx were 13.4% versus 23.4% for women with other types of blockage. And women with untreated hydrosalpinx saw higher rates of early pregnancy loss, 43.65% versus 31.11% for the control group. So no matter which way you play it, having a hydrosalpinx, not a blockage by adhesion or anything else, but having untreated fluid held in the fallopian tubes impairs conception, impairs live birth rate, and also increases miscarriage rates. And this is what a hydrosalpinx chart looks like. It's an odd chart. It doesn't make any sense. You kind of see ovulation actually happen in this chart around at the right time, around day 16, but look at the luteal phase. It's all over the place. And look at the temperatures. Low overall, but not so low we might think, big thyroid problem there. Hydrosalpinx basal body temperature charts just are all over the place. So you want to have a look at them and you're thinking, yes, she's having a regular cycle. Yes, I can see she's ovulating. Nothing's really out of whack, but something's not right. And then you just ask about previous STDs. You ask about if they've had their tubes flushed. You ask how long they've been trying, look at their age. And you think, maybe while I'm treating, I'm going to go and just send them for a check. So there's different things you can do. You can have surgery to clear it. It's called a salpingectomy, and it's done laparoscopically. But actually, you might look at something called sclerotherapy, which is probably just as effective and less invasive. And what happens is it's done with ultrasound, and it just aspirates fluid from the tube. So you inject it with a solution that irritates it, and in response, the tube swells shut and it pushes out any fluid it doesn't need. So it's quite a simple one. It can be done at the same time the tubes are checked. So if you've had a client have their tubes checked and say, oh, they injected the dye and then they found that after they flushed it, things were better, the flushing it is this particular method. But equally, if you know that something has been flushed out of that tube, that tells us from a TCM perspective, again, about what's happening with their fluid metabolism, what's happening with their spleen, that you need to pay attention to treating the Sanjiao. You need to understand from a TCM point of view what the effect of having that stagnant fluid, that sort of toxic fluid in their body for so long before might have been. So is there damp heat in there as a result? Did it come from an untreated STD or an STD which was treated years before but was still hanging around? So just give you clues from a Western medicine point of view what's going on. My take on this is that actually this is quite significant. We know that sometimes there's DNA left over from old STDs. We know that sperm can often show chlamydia even when it's been treated, and it's picked up in women too. We know that they're hanging around in the body. There's even in the endometrium, when we test menstrual blood, we can see that there's old STD DNA hanging around. And that tells me from an immune system point of view, there's been an irritant in there that might well be having an effect long-term on how the body's going to be perceiving an embryo and holding on to it. So we're looking at all of those factors in it. And so I'm just going to recap when we're looking at a temperature chart and hydrosalpinx. What you're looking at is no real biphasic chart, usually a short luteal phase, usually a poor sustaining of that rise, and then a chart that is just a little bit of this and a little bit of that and nothing really special. So you're looking for something that just doesn't add up and make sense. So I realize that when I'm saying this, it's a very general thing, but that's what it is. And I'd rather, you probably won't see this in the book, so I'd rather you have the opportunity to hear this and see it and understand it, and at least have it in the back of your head when you're doing your fertility detective work and figure out what you're seeing. Then you never know about it and you never see it. All right, let's now look at LUFS. Anyone know what LUFS is? Again, something you're not going to see very often. And again, you know, in asking me to talk, you're not going to get the very basic stuff. You're going to get a little bit more high level stuff. So this might not be something that you see very often unless you treat fertility a lot or for a long time. But again, I really want you to understand what it is so you're competent to treat it once you see it. So it's called luteinizing unruptured follicle syndrome. And it's defined as a failure of ovulation in which, despite the absence of follicular rupture and release of the egg, the unruptured follicles undergoes luteinization under the action of LH. In such cases, normal production of progesterone and duration of the luteal phase of the cycle could be seen. But this is actually a form of anovulation. Anyone understand what that means? So it's actually meaning that you're not really ovulating properly. It looks like you're fine, but you're not really ovulating properly. And it's seen in about 10% of menstrual cycles of normal fertile women. So it does happen. And it certainly a higher incidence than 10% has been consistently reported in infertile women. And it's been linked to lots of other conditions. So you're more likely to see LUFS if someone has a previous history of STDs, a previous history of all the things we've talked about today, endometriosis, previous history of pelvic pain or adhesions, previous history of hydrosalpinx. And actually, if you've had a really long history of using non-steroidal anti-inflammatory drugs, even if it's just somebody who has, let's say, fibromyalgia and has used a lot of ibuprofen in their lives, you're much more likely to see this happen. So little clues for you, little crumbs. And you can see this in both spontaneous and stimulated cycles. So when you look at it, it's a pretty normal looking chart, but ovulation just doesn't really happen very well. So in this case, we had an LH surge on day 16, and then this massively long luteal phase, but no pregnancy. And in fact, this went on for 2 more weeks. So I didn't bother charting beyond this, but so it looks like a pregnancy chart in effect in a lot of times, but it's just a really rubbish kind of cycle that happens. So you've got to get that client back on track again. How do you think you'd do that using TCM? How would you get a client with LUFS back on track? So it's an unruptured follicle. How do you think you get that client back on track? Any ideas from a TCM point of view? I'm gonna look at my chat now. So what's an unruptured follicle? What could that be called? Any ideas? A simple cyst. So effectively you treat LUFS like you would a simple cyst. So you look at fluid metabolism, you look at blood stasis, you look at clearing and resolving all of the fluid and all of the chi that has accumulated in that area, and then you start them again. This is not you'd never do a completely moving treatment without any element of tonifications, but I'd say the proportion would be like 85% moving and clearing to a very small amount of tonification, and you need to start them again. So we're coming to the end. I'm just going to talk a little bit about recurrent miscarriage, and then I'm going to stop and answer all of your questions. We're going to look at one thing about perimenopause too, actually. So looking at recurrent miscarriage, this is not from an immune system point of view. I'll talk to you about that in a minute. This is just a very plain kind of, this is not a great chart. This is not someone who's going to continue to be pregnant. And the reason I show you this is because a lot of the time, a pregnancy chart or a chart looks absolutely fine. You don't know they're going to miscarry unless you've taken that history well. What's the first place you start? Does anyone know from a Western medicine point of view with recurrent miscarriage? What do you check? Any ideas? You always check their progesterone levels. You just make sure, very first stage, you make sure there's enough progesterone in the body to help get them pregnant and keep them pregnant. And clues with recurrent miscarriage that might not be sufficient is when that spleen and that kidney yang are not supporting an adequate luteal phase. So even 1 day less than 12-day, the minimal 12-day luteal phase will tell you that the spleen and the kidney need support, and will tell you that you need to check their progesterone levels. So this looks like a pretty ordinary temperature chart, right? Pretty okay. You can't actually tell whether someone's going to miscarry from a temperature chart. Unless, and the exception to that is, unless the temperature chart starts to head down way before the day before the period. So implantation should happen in a normal cycle between 4 and 7 days after you ovulate. And ideally, in that between 4 and 7 days after ovulation, your temperature will head up, not down. But if the temperature heads down in those 4 to 7 days, or continues to go down from there, you know that conception might well have happened, but it's unlikely to stay. And when you have recurrent miscarriage clients, often the only way you know that they've been pregnant is if they tell you they've been pregnant, because women know in their bodies when they've been pregnant, or if you get a faint line of a positive pregnancy test when they're due, and then the period arrives. So those little clues just tell you something's not quite right. And in my opinion, you need to ask them to stop trying. You need them to give you enough chance to fill up their bucket and stop the hole where the chi is pouring out before they should and can get pregnant again and have a good chance of staying pregnant. Now, I'm going to show you a reproductive immunology recurrent miscarriage chart. I'm not even going to go into reproductive immunology. It's so much more complicated than we need to do today. But one point I am going to make about it is, what can you see in this at the beginning of this cycle? Can anyone say in the chat what they see at the beginning of the cycle the temperature's doing? Yeah, exactly right. So it's well above where it should be, which is no higher than 36.3. And not only is it well above it, but it's staying above it. When it comes to reproductive immunology and when it comes to recurrent miscarriage, you're always going to be seeing a very visible element of blood stasis in the follicular phase. And so again, when you're treating it the month before and not with the period. It's what I call, there's a whole section in my diploma, I call it the adaptive response, and I go into quite a lot of detail about that. And there's a lot of fear in us, and I talk about a lot about this, there's a lot of fear of us in breaking blood and moving chi in the luteal phase, but it's vitally important when you're dealing with this. So let's look at perimenopause, and this will take us to our last slide. Perimenopause is something that we see all too often in our fertility patients, because they're coming later and later, and they're more and more stressed. And perimenopause, according to a GP, is not necessarily perimenopause according to us, because what we know is that stress can send you into hormones that look like you're going into menopause. So never take it as a fact. Perimenopause is going to have elements of kidney issue, it's going to have elements of empty heat in it, it's going to have all sorts of blood deficiency, kidney yang deficiency. It's such a mixed bag in terms of diagnosis. But one thing you'll see is an irregularity to the cycle quite often, a little, few times short, few times long, an irregularity to where ovulation happens. And what you're going to know is that as soon as you can get to grips with the chi deficiency that you'll see there, plus their lifestyle, you'll be able to see quite a different chart appear, and you'll be able to see quite a different result in blood tests. So let's look at this temperature chart. Anyone want to, this is a pregnancy chart, by the way. And it's worth me saying that when she first came, this is the third cycle of treatment. And when she first came to me, does anyone know what the FSH level should be? The highest bit should be no more than 12. She had a 36 when she came to me. And this cycle, when we tested it, it was down to 9. So I test every cycle, and I say, and this is the cycle I said, right, you can try this month, it's come down. Because when it's really high, you're going to predispose to miscarriage too. So you want it to be down low before you start treating it. But when do you think that she ovulated here? And this was many years ago. This is a really good example of why I now ask my clients to wait a little bit longer, because I had to treat her into her pregnancy because this happened a little bit too soon. Day 13. No, actually, it was earlier than that. It was actually day 10. And that's really common in perimenopause. Yay, Alan. I can absolutely see why you think day 13, because we're kind of looking at that 3/6 rule, right? But actually, it was day 10, because if you have a look at these 3, these are higher than the 6 that have gone before. And we had an LH surge. And it's really common with perimenopause that they're going to ovulate early. They're usually going to be ovulating sometime between days 9 and 12. And as you're treating, you need to be pushing that later and later, because when they're conceiving, as this woman did, that early, then what we're seeing is that the egg is a little bit immature within the cycle, and so she's much more likely to have issues. And she had spotting in early pregnancy. So if we count 12 days from when I saw this, I had to count 12 days from day 10, and we did a pregnancy test on day 23. And then she started spotting on day 25. So I was right in there with treating her. So this is a pregnancy chart, and you can see this bit is the bit that's pregnant. So with perimenopause, when you're starting to treat, you have to be aware that they have the potential to get pregnant, but that if you don't have enough time to do the work beforehand, you're going to have to treat them, and you're going to tell them right up front, if you get pregnant quickly with me, I want to see you into pregnancy in the way I might not need to if I get a chance to treat you beforehand. All right, hang on a minute. I'm going to do one more, if you don't mind. I'm going to hear. Thank you very much. I'm looking forward to seeing any of you who would like to come and train with me. I'm needing some more practitioners. And here's how you do it. A link to my online learning platform. So let me stop now and get some questions. Susan, do you want to just say them to me and I can say them?
Yeah, I've got a few questions here that have been going on since you started.
Okay.
The first one was about, could you explain a bit more about cold in the uterus?
That's a very broad question. Can the person be a little bit more specific and let me come back to that, if that's okay?
That was Ray Mann asked that right at the beginning.
Be a bit more specific, then I can answer it much better for you.
Okay, so Ray, if you want to ask a little more specific.
You see in clinic the signs and symptoms too, because then that will be more helpful for everyone. Okay.
So
yes.
the second one was when you were talking about PCOS, somebody asked about PCOS in a 16-year-old.
Yeah.
So again, I don't understand.
I'm not sure I understand the question. Please
So,
straight further.
I think it was maybe to do with lifestyle, and if it's 16.
Well, you first have to understand that you need to give someone enough time to get into some sort of cycle before you can diagnose them. So depending on when they had menarche, that would impact the diagnosis. And also people can, in the early years, it's not a fixed diagnosis. If you can intervene at that point, they can grow out of it. So if you settle on a diagnosis at 16 and then you medicate, you fix them with a problem. But yes, it is possible for someone to have PCOS at 16.
So she's come back and said the question was about etiology. 16, started periods at 13, vegetarian, losing hair, but on the put on.
Okay. I should be really upfront about this. I don't treat vegetarians and vegans anymore. I'm realizing that half the people who are looking at me are now getting their backs up. Okay, here's the thing. I don't have a prejudice against it per se, but my work in immunology has taught me something really interesting, and that is that most Westerners can't metabolize the amount of grains, the pulses and the legumes and the protein that they need to stay healthy. Protein is a building block for fertility. And as a result, most people who are vegetarians and vegans don't eat very well. There's a lot of synthetic protein. They don't work very hard. A lot of them, they rely on carbohydrate, quick fix fructose, all sorts of things. And when they are doing it well, it's very few people who will take the time to germinate and sprout all of their grains and their legumes to the point where it can make a big difference. And if you are familiar with Terry Wiles and the Wiles protocol, that was a huge influence in my thinking around this. And I put that together with the years of auditing I did of my practice. And what we see is that when you are on a diet that doesn't include animal protein and that doesn't include all of the good kind of proteins you need as a vegetarian, it doesn't include sprouting and so on, it actually impacts the gut, it impacts the brain, it impacts the immune system. And it has a huge effect on fertility, both earlier and later on in life. I'm really giving you such a skim over. I do this subject a disservice. I know I don't have time to explain this properly, but do investigate Terry Wiles if you're interested in understanding some of this. But what I will say is that looking at my clients and looking at my success rates, a number of years ago, I started to be able to very clearly see the difference in where I was getting in terms of my clients' hormone levels when I saw before and after blood tests, when I saw my success rates in terms of them both getting and staying pregnant, and I had to go searching for what the factor was and started to realize it might well be the inclusion of animal protein. When someone is vegetarian at a very young age, it does also affect future menstrual cyclicity, because at a very young age, very few of them are eating properly, even when they're not vegetarian. But when they're a vegetarian or vegan diet, there's often a lot of synthetic, a lot of dairy, a lot of carb, and it really makes a big difference. So if you are sensitive to PCOS and then you add the vegetarian diet done improperly, that is often the environmental factor that tips you into a problem. But yes, when you're 16 and you have acne and hirsutism and all sorts of things, it does display itself very clearly.
Great. Hopefully that's answered that. She's put tons of salads, exclamation mark, have started to change her diet. So she's already trying to
look, even if you can only settle on fish and bone broth, that's still, a step in the right direction.
So going back to the cold in the uterus, it was cold in the uterus caused by heat specifically.
So let's look at endometriosis when it comes to talking about that. So endometriosis, when you have adhesions inside, you have a constant level of bleeding inside, you can, stasis can generate heat. And heat in itself dries blood and further encourages stasis. And when you are in that place where everything is locked, then no yang can penetrate. Yang can't access. So you end up with cold. So cold is the end product after heat. But similarly, you can start with cold because cold is congealing in its nature and can also cause blood stasis. And when the blood stasis is there and you get locked up, you can end up in heat. So it's really unpicking the pathological flow to understand how that how the diagnosis has eventuated that will tell you whether there is cold transforming into heat, heat transforming into cold, or indeed if both of those things are there. Then plus you're looking for the actual symptoms of cold in the uterus and marrying that up.
Okay, great. Another question, part of it was me. Could you just go over the dose of the Agnus Castus again? And somebody else asked if you recommend a brand, whether you can recommend a brand.
I like Vogel, Vogel drops. I will find my instructions again. So sorry. Where did I put my notes? I separated out all the case histories I prepared in case we had time, but as always, over-prepared, so no time. Right, I'll go through it again. So if women have a delayed ovulation with a slightly high LH, so raised above FSH is what I mean by slightly high, you use it only in the luteal phase. And this is an instruction that is for women who have roughly a 32 to 45 day cycle. For women who have longer periods of time between cycles or who have amenorrhea, no periods, then daily use for 4 to 6 months is indicated. Once some cycle is established, so some semblance of cycle that lands you between 32 and 45 days, you stop doing it daily and you go to just in the luteal phase. All dosages to be taken in the morning and around 1500 micrograms.
Thank you, that's lovely. Any more questions? If anybody, so there's a thank you about the uterus, about the cold in the uterus, that's great. So I don't see any raised hands. So has anybody got anything else? Any other questions? Oh, yes. Yes, sorry, Jill. The study about the hydrosalpinx, can you give a reference for that, please?
Yes, absolutely can. Hang on, I've got to find it. Bear with me. So I can give you a reference, but it is a very long reference. Here we go. academic.academic.humrep/article/14, the numbers 14/5/1243/766
Great.
There's mud.
Yeah, great. Well, I think you've provided us with a lot of information there. Right, let me see. Oh, have you got the authors? Sorry.
I mean, you'd have to look it up.
So the authors for that study?
No, I'm sorry. I only have that link. I didn't put it in my notes, the author's name.
Okay.
You have to look up the link.
Right, yeah. Okay, so there will be a recording of this session on the Let's Talk About section in the website. So thank you, everybody. Thank you, Naava. That was a really excellent presentation on the BBTs. It was really good to see that.
I hope.
No, it was really, really useful. I mean, it was fantastic because we see so many BBTs and, you know, there are so many things in there that it's just useful. I thought the 3/6 was a wonderful thing to be able to look at. And everybody's saying thank you. They really appreciated that. So thank you, everybody, for joining us. This was the last in our Let's Talk About Fertility. We are looking at our next series of Let's Talk About. So if you follow the e-news, you will find out what our next Let's Talk About will be about. So thank you very much. Thank you, Naava.
Pleasure.
Okay, thanks everyone.
This was the easy bit of my Sunday morning. I'm now going back to childcare. It's much harder.
Well, enjoy the rest of it. Yeah, well, we've got a heavy storm here, so I'm just glad my internet didn't go. Bye.
Bye, everybody.